Welcome to the audio digest of the American Journal of Psychiatry. This is Michael Roy with highlights from our October issue. Featured in the journal this month, TADS Take Home. Our review article summarizes take-home messages from TADS, the Treatment for Adolescents with Depression study. Next, Affective Change. We'll feature a study in which depressed patients had a change in negative affective bias after one subtherapeutic dose of an antidepressant. Then, suicidal tendencies. Two studies examined factors related to suicide. One revealed an association between the familial aggregation of suicide and cluster B personality traits. The other one explored associations among suicide attempts, gender, and sexual abuse. And finally, boomer binging. We'll conclude with a national survey of at-risk and binge drinking among middle-aged and elderly adults. But we begin with clinical messages from the Treatment for Adolescents with Depression study, where John March and Benedetto Vitiello review the major TADS findings. Now, TADS was a 36-week randomized placebo-controlled trial with 1 year of naturalistic follow-up in which 4 treatments were compared: clinical management with fluoxetine, clinical management with placebo, cognitive behavioral therapy, and a combination of fluoxetine and CBT. For the first 12 weeks, fluoxetine and placebo were administered under double-blind conditions, while CBT and combination treatment were open. The subjects assigned to placebo were treated openly after week 12 and weren't included in the later analyses. Because there was no placebo group beyond week 12 and attrition gradually increased, the results from acute treatment are more robust than those from later stages. The patients in the study were broadly representative of indisputably ill depressed adolescents seeking treatment. Most were moderately to severely ill, and about half had at least one other psychiatric disorder. More than half had received previous treatment for their current episode. The study included a mix of younger and older adolescents of both genders, with excellent minority representation and wide variability in socioeconomic circumstances. After 12 weeks of treatment, CBT alone was far less effective than fluoxetine alone or the combination of CBT and fluoxetine. The response rates were 71% for combined treatment, 61% for fluoxetine, 43% for CBT, and 34% for placebo. CBT caught up with fluoxetine by week 18. Also, combined treatment reached its maximum benefit at week 18, which was 3 months earlier than the maximum for either fluoxetine or CBT alone. All treatments converged by week 36, with response rates ranging from 81 to 86%. Secondary outcomes analyzed at week 12 included functioning and quality of life, remission, acceptability, tolerability, and safety. In these areas, combination treatment, but not fluoxetine alone, was superior to CBT and placebo. Overall, fewer than 1/4 of the patients were in remission at week 12. At week 36, however, the remission rates ranged from 55% for fluoxetine to 64% for CBT. The rates of response at week 36 ranged from 62% for fluoxetine to 80% for combination treatment. It appears that 6 to 9 months of treatment is adequate for the average patient, since the relapse rate was higher for patients who discontinued treatment early, and patients given placebo initially who were switched to open treatment after week 12 caught up to the active treatments by month 9. Across those 9 months, suicidal ideation and events were more common in the patients treated with fluoxetine alone than in those given CBT alone or the combination. The rates of suicidal events were 15% for fluoxetine, 8% for combined treatment, and 6% for CBT. Thus, patients receiving medication alone should be informed of the risk of a suicidal event and monitored carefully. Patients and providers may wish to begin treatment with CBT alone to avoid the risk of antidepressant-induced suicidality, advancing to medication only when the response to CBT is deemed inadequate. This may be an especially good strategy for patients who are non-suicidal, mildly ill, and sociodemographically advantaged. At week 12, fluoxetine showed the greatest cost-effectiveness, followed by combined treatment. Over 9 months, CBT and combined fluoxetine-CBT treatment were equally cost-effective. More important, combined treatment was superior to fluoxetine alone, largely because of the healthcare costs due to suicidal events associated with fluoxetine. Since the original publication of the TADS results for acute treatment, 2 other important publicly funded clinical trials of treatment for adolescent depression have been reported. The Adolescent Depression and Psychotherapy trial, known as ADAPT, was conducted in the United Kingdom. Depressed adolescents were first treated with nonspecific psychotherapy. Those who didn't respond were then randomly assigned to treatment as usual with an SSRI or the combination of an SSRI plus CBT. No differences were detected in efficacy or safety at the end of 28 weeks. The apparent discrepancy between these results and the outcomes in TADS may be explained by the greater illness severity of the British sample, the greater intensity of CBT in TADS, and the fact that all patients in ADAPT had received psychotherapy as part of treatment as usual. The other major trial is the treatment of resistant depression in adolescents, known as TORDIA. The participants in TORDIA were youth who hadn't improved following a first trial of medication, and like TADS, it supported the superiority of combined treatment. However, neither ADAPT nor TORDIA demonstrated the protective effect of CBT on suicidal ideation or events that was seen in TADS. We'll next turn to the article by Alexander McGurr and colleagues, who report that familial aggregation of suicide is explained by cluster B traits. There's substantial evidence that suicide aggregates in families, but it almost always occurs in the context of psychiatric illness, particularly mood disorders. Thus, a central question has been the independence of the liability to suicide and the liability to psychiatric disorders. In addition, several lines of evidence suggest that cluster B personality disorders and associated traits, such as impulsivity, hostility, and aggression, may act as intermediate phenotypes of suicidal behavior. To examine these issues, suicidal behavior, psychiatric disorders, and traits associated with cluster B personality disorders were assessed in 3 proband groups and their relatives. The 3 proband groups were individuals who committed suicide during an episode of major depressive disorder, living depressed probands with no history of suicidal behavior, and living comparison probands without either depression or suicidal behavior. Psychological autopsy was used to determine major depression in the 51 probands who died by suicide. For comparability, interviews with proxies were used to characterize the living depressed probands and comparison probands. Direct assessments of more than 200 first-degree relatives were also conducted, and nearly 500 more were assessed with the family interview for genetic studies. History of suicidal behavior was assessed with the Mental Health Clinical Research Center Suicide History Form. Impulsive aggression and cluster B personality traits were measured with the Brown-Goodwin History of Aggression, the Barrett Impulsiveness Scale, the Bus-Durkee Hostility Inventory, and the Temperament and Character Inventory. The depressed probands who committed suicide and the non-suicidal depressed probands had higher scores than the comparison subjects on 3 of these measures, but there were no significant differences between the 2 depressed groups. Among the relatives, the families of the 2 depressed proband groups had similar rates of major depressive disorder, approximately 15%. The rate was 3% for relatives of the comparison probands. The rates of suicide among the relatives followed a gradient. The rate for relatives of the depressed probands who committed suicide was 1.6%, compared to 0.6% for relatives of the non-suicidal depressed probands, and 0% for relatives in the comparison group. Suicidal behavior was identified in 11%, 7%, and 3% of the groups, respectively. The gradient in these rates suggests that there's a degree of overlap in the familial loading of suicide and depression. More important, it indicates a familial component for suicide outside the domain of liability to psychiatric illness. On the measures of cluster B traits, relatives of the depressed probands who committed suicide had higher scores for novelty seeking than relatives of the non-suicidal depressed probands. They also had lower scores for persistence than relatives in both of the other groups. In addition, relatives of the non-suicidal depressed probands had higher scores for hostility and harm avoidance than relatives of the comparison subjects. The ratings of impulsive aggression and cluster B characteristics were combined into an aggregate measure. Among the probands, the scores followed a decreasing gradient. The overall difference was significant, but the difference between the probands who committed suicide and the living depressed probands fell short of significance. A similar gradient was seen among the relatives. The cluster B traits themselves were familial. This was established by classifying the probands in all 3 groups according to whether or not they met the criteria for a cluster B personality disorder. The relatives of probands who had cluster B personality disorders had higher aggregate scores for cluster B traits than relatives of probands without cluster B disorders. The relatives' cluster B score was also positively associated with suicide attempts in the relatives. Testing was conducted to determine whether cluster B traits mediated the effect of familial vulnerability to suicide. Mediation testing demonstrated a significant effect for cluster B traits and a large decrease in effect for familial predisposition, which no longer significantly contributed to the statistical model. Estimates revealed that increased cluster B traits were associated with suicidal behavior, suggesting that they act as intermediate phenotypes and account for a portion of the familial vulnerability to suicide. In his editorial commenting on the McGurr study, David Brent notes that a distinct biological and clinical profile in depressed individuals with suicidal behavior has been shown by postmortem studies, in vivo biological studies of suicide attempters, and family genetic studies. This profile includes decreased central serotonin activity in the ventromedial prefrontal cortex, higher levels of impulsive aggression, and familial aggregation of suicidal behavior that's not explained by the transmission of psychiatric disorders like depression. Moreover, changes in serotonin function and greater familial loading for suicidal behavior are related to high levels of impulsive aggression. The study by McGurr and colleagues addresses the question of which intermediate phenotypes of suicidal behavior best explain its distinct pattern of familial transmission. These results are consistent with previous findings of an association between cluster B traits and suicidal behavior, a higher level of cluster B traits as a function of family loading for suicidal behavior, heritability of cluster B traits, and mediation of familial transmission of suicidal behavior via the transmission of impulsive aggression. Nevertheless, there are at least 3 questions that can be raised about impulsive aggression as an endophenotype for suicidal behavior. First, cluster B traits are themselves complex and can likely be deconstructed into simpler and more homogeneous traits that can be more directly assessed. Laboratory measures of decision-making, risk assessment, and emotion regulation have been shown to have distinct neurobiological and genetic correlates, and these may help to refine the impulsive-aggressive endophenotype. Second, while cluster B traits are heritable, the majority of their variance in familial concordance seems to be explained by environment or measurement error. Moreover, the familial transmission of impulsive aggression may be complicated by co-transmission of child maltreatment. Thus, while impulsive aggression does appear to explain the familial transmission of early-onset suicidal behavior, it may do so through mechanisms that are both environmental and genetic, which may undercut its utility as a purely genetic endophenotype. Third, it's tacitly assumed that impulsive aggression is orthogonal to depression, when the two are interrelated. In the McGurr study, the levels of both suicidal behavior and cluster B traits among the non-suicidal depressed probands and their relatives were intermediate between those of the depressed probands who committed suicide and the healthy comparison probands. If these two sets of traits are really independent, one wouldn't expect to find any difference between the non-suicidal depressed and comparison probands, and both would be equally distinguished from the depressed probands who committed suicide. Retrospective studies show that an earlier onset of mood disorder is associated with a higher rate of cluster B disorders, and prospective studies indicate that higher levels of impulsive aggression predict earlier onset of mood disorder and suicidal behavior. Impulsive aggression may be a precursor of depression, a form frust, or a predisposing factor in life events likely to bring on depression. Conversely, early onset of mood disorder may impair the development of adequate strategies for affective regulation that are needed to constrain impulsive aggressive tendencies. Furthermore, studies have shown a relationship between high family loading for mood disorder and suicidal behavior, abuse in the parent and in the child, and earlier onset of mood disorder. This indicates that the age at onset of depression, early childhood adversity, and impulsive aggression should be characterized in future genetic studies. In our next article, The Relationship of Suicide Attempts, Gender, and Sexual Abuse, Paul Bebbington and colleagues present data from the British Psychiatric Morbidity Survey. Since both sexual abuse and suicide attempts are more prevalent in women, the authors considered the possibility that sexual abuse contributes to suicide attempts. The authors examined whether the association of sexual abuse with suicide attempts was more robust in women, whether the proportion of suicide attempts attributable to sexual abuse was greater in women, and the extent to which the effect of sexual abuse was modified when current affective symptoms were taken into account. The participants were from a random sample of British households, and more than 8,500 were interviewed. During the interview, information on non-psychotic mental illness was assessed with the clinical interview schedule. To determine the effects of gender and sexual abuse on suicide attempts, the authors calculated both the odds ratios and the population attributable risk fraction for each sex. The odds ratio represented the strength of the association between abuse and suicide attempts, while the population attributable risk fraction was an estimate of the proportion of suicide attempts that could be ascribed to sexual abuse. In theory, this fraction indicates how much the suicide attempt rate would be reduced if no sexual abuse had occurred. It's dependent on both the prevalence of the exposure to sexual abuse and the strength of the association of sexual abuse with suicide attempts. The relative effect of gender and sexual abuse on lifetime suicide attempts and on attempts within the past year was established by logistic regression analysis. The effect of the score on the clinical interview schedule was then incorporated in order to test the hypothesis that affective symptoms mediated the relationship between sexual abuse and suicide attempts. Women were significantly more likely than men to report suicide attempts over the course of their lives. The rate for women was 5.1%, and the rate for men was 3.5%. However, the frequencies in the past year were equal. Sexual abuse was also more common among women, 5.2%, compared to 1.6% in men. The population attributable risk fraction, indicating the proportion of lifetime suicide attempts ascribed to sexual abuse, was 28% for women and 7% for men. When sexual abuse and gender were entered into the logistic regression analysis together, there was a slight reduction in the odds ratio associated with sexual abuse. There was a proportionately greater reduction in the odds ratio associated with gender, which no longer was significant. The total score on the clinical interview schedule was strongly associated with both suicide attempts and sexual abuse. When the score was added to the model containing gender and sexual abuse, there was a further small reduction in the odds ratio for gender. The odds ratio for sexual abuse was reduced by more than half, which suggests that the effect of sexual abuse on suicidal behavior originates in its persistent effect on mood. Now we'll return to the treatment of depression, with an article by Catherine Harmer and colleagues who report an effect of acute antidepressant administration on negative affective bias in depressed patients. Experimental evidence suggests that depressed patients are more likely to remember negative than positive emotional information, and that compared to healthy volunteers, they interpret social signals, such as facial expressions, as either more negative or less positive. Antidepressant drugs may produce their clinical effects by normalizing these negative biases. In healthy volunteers, antidepressants have early effects on emotional processing, even in the absence of mood changes. This study examined whether these early changes also occur in depressed patients. The study included 33 patients with major depression, along with matched healthy subjects. The patients had been medication-free for at least 3 months. On the test day, mood and anxiety were measured, and then the participants took either placebo or 4 milligrams of reboxetine. The anxiety and mood ratings were repeated 3 hours later. As expected, the baseline scores of the depressed patients were higher than the ratings of the healthy volunteers. 3 tests of affective bias were also administered. One task measured recognition of facial expressions representing 6 emotions: happiness, surprise, sadness, fear, anger, and disgust. Each emotion was presented at 10 different intensities, and the intensity at which the participant consistently identified the emotion was determined. Reaction times for correct responses were also measured. The second task was emotional categorization. Words representing 60 personality characteristics were displayed, and the participants were asked to categorize them as likable or unlikable. Reaction times for correct identifications were also computed. 15 minutes later, the participants were asked to recall as many of the personality traits as possible. The numbers of positive and negative words recalled were computed. To establish the effects of depression, the results from each task were first analyzed for the participants who received placebo. The depressed patients showed reduced perception of facial expressions of happiness and surprise compared to the healthy volunteers, but no difference in the recognition of the other emotions. There was also no effect of depression on the speed of correct responses. Reboxetine had no effect on the mood and anxiety ratings of either group. However, it increased the recognition of happy facial expressions in both the depressed and comparison subjects. It had no effect on recognition of the other facial expressions or on reaction times. On the second task, categorizing characteristics as agreeable or disagreeable, the depressed patients in the placebo group took longer to respond to the positive items compared to the healthy volunteers. Reboxetine decreased the response time for positive qualities in both the depressed and healthy subjects. Depressed patients in the placebo group also showed worse recall of the personality descriptors, and this was particularly evident for the recall of positive items. Reboxetine improved memory for positive items in the depressed group, but not the comparison group. These improvements suggest that there's a delay between the effects of antidepressants on emotional processing and their effects on mood. An increased tendency to interpret social signals as positive could reinforce social participation and social functioning, which over repeated experience improves mood and other symptoms of depression. Since negative biases in information processing among depressed patients are the explicit target for cognitive behavioral therapy, cognitive theories of depression may also be relevant to antidepressant drug action. The findings also have implications for drug development and screening. If acute effects are seen reliably with effective antidepressants in depressed patients, then emotional processing may be a way to screen novel candidate antidepressant agents before clinical trials are begun. It's also possible that these effects could be used to predict eventual response in depressed patients starting treatment. We'll conclude this program with a report by Dan Blazer and Lizzie Wu on the epidemiology of at-risk and binge drinking among middle-aged and elderly community adults. Earlier studies have suggested that binge drinking is hidden from many clinicians because the usual correlates of alcohol use disorders may not apply. In addition, the frequency of alcohol use among middle-aged and older individuals is increasing, possibly because the cohorts now reaching these ages have consumed more alcohol than past cohorts. However, the adverse health effects of binge drinking present more negative consequence in later life, when natural body defenses decrease and multiple illnesses may be aggravated by binge drinking. The present study was based on data from the public use files of the National Survey on Drug Use and Health. A total of more than 136,000 respondents completed the surveys in 2005 and 2006. They were interviewed privately in their homes, and their names were not collected with the data. To increase the validity of the respondents' reports of their drug use, the data collection involved a combination of computer-assisted personal interviewing and computer-assisted self-interviewing. Nearly 11,000 of the respondents were 50 years of age or older. Age, sex, ethnicity, educational level, current marital status, current employment status, and annual family income were examined in relation to alcohol consumption. The respondents were asked about their use of alcohol during the past year. Those who reported using alcohol were asked how many drinks they had usually consumed on a drinking day during the past 30 days, and how many days they consumed 5 or more drinks on the same occasion. The respondents were classified into 4 mutually exclusive groups: no alcohol use, low risk use, at-risk drinking, and binge drinking. Low risk was defined as no more than 1 drink per day within the past 30 days. At-risk drinking was defined as 2 or more drinks per day on average, and binge drinking was defined as 5 or more drinks on one occasion. Assessment of serious psychological distress during the preceding year was measured using the K6 screening scale. Overall, 66% of the male respondents and 55% of the female respondents reported alcohol use during the past year. Men showed higher rates of both at-risk drinking and binge drinking. The rates of binge drinking were 20% for men and 6% for women. At-risk use was more frequent in respondents 50 to 64 years old than among those 65 or older. Still, in the older age group, 14% of men and 3% of women reported binge drinking. Compared with respondents who reported no alcohol use, those who reported binge drinking were more likely to use tobacco and illicit drugs. Men who reported binge drinking had higher incomes and were more likely to be separated, divorced, or widowed than men with no alcohol use. In women, the rate of binge drinking was higher for African American women than for Caucasian women. Additional comparisons were limited to the 3 groups who reported any alcohol use. Among women who reported using alcohol, higher odds of binge drinking were observed for those who were aged 50 to 64 years old, African American, and less educated. Among men, greater odds of binge drinking were observed for those ages 50 to 64 years. In addition, illicit drug use was associated with binge drinking among men, while non-medical use of prescription drugs was associated with binge drinking among women. For both men and women, at-risk or binge drinking was not associated with psychological distress. Since the variables were identified through controlled analyses, the effect of psychological distress may be effectively accounted for through other variables. In addition, middle-aged and older adults with at-risk and binge drinking may be especially easy to miss in clinical settings because they do not report overt stress at the time of the interview. Many screening instruments, such as the CAGE questionnaire, are of little value in identifying people who binge drink. Since the potential health and safety problems are even greater for older individuals, it may be advisable for clinicians who screen for alcohol problems in this age group to specifically ask about binge drinking. This concludes the audio highlights of the October issue of the American Journal of Psychiatry. We invite you to our website, ajp.psychiatryonline.org, for the full text of these and other articles, including author affiliations and financial disclosures. We also welcome comments regarding this audio. they can be emailed to Jane Weaver. Her email address is jweaver@psych.org. Next month, our audio highlights will include Bipolar II Postpartum Depression, Improving Care for Bipolar Disorder, the influence of neighborhoods on outcomes for patients with dual diagnoses, and a trial of vigabatrin for cocaine dependence. We hope that you'll join us again. Thank you.